pain management modalities, again multimodal approach, and you all know that there is a preemptive analgesia and multimodal approach to the pain, and it's a change in the pain. Again, is the one tablet coming, what you call Jarnavix, is not yet available in India. It's a cetirizine, and it will come shortly. And people say that there will be game changer in pain control. And again, liposomal bupivacaine, patient control analgesia, cryoneurolysis, peripheral nerve stimulation. And you can see that from anesthetic point of view, the death on table is gone. And again, peripheral blocks, everything has come so well, and it is wonderful to get any complex patient with a 20% ejection fraction also operating by the anesthesiologist, technology and expertise. Now, artificial intelligence and machine learning, as I told you, the data analytics in clinical research and algorithmic techniques to surgical decision making and diagnostics. Already pathology, microbiology, radiology are getting out of the conventional wisdom, and there will be a time where there is no more job for the pathologists, radiologists and microbiologists. And so, advances in artificial intelligence, predictive models for complications and outcomes. So you feed a patient with all the data, comorbidities, and predictive model will come how much percentage this patient is going to end up in infection, how much this patient is going to end up in a dislocation, like that. The variables of the patient. So like that, it can diagnose and classify the fractures, and it automated measurements of the component position. You don't need a scale and the measurement with 3D graphics for that. So this is the machine learning. AI-based surgical plan, already Zimmer Formus is there, hip planning, and it will completely give you including limb discrepancy, and it accounts for spinopelvic issues also. Again, before going into theatre, you will be knowing where your implant is going to be, what is the offset, what is the limb discrepancy, all that. Now another advance is called smart implants, like a smartphone and smart watch, and wearable technology. Smart implants, sensors are incorporated into the totally process. Accelerate. Doctors can know real time about the range of movements. Your patient has gone home 1,000 kilometers away, and he will send the video, or he doesn't even send the video. His smartwatch will send the data to you, and you can know how much he is progressing, whether there is any impediment or post-operative rehabilitation block. Future information on load distribution, gauge analysis, and early detection of component loosening, migration. Very important point. So the early signs of loosening will give us a good time to intervene and do a revision surgery preemptively before we do the bone loss. Again, smart implants, you can see that the tip of the implant has got a sensor, and that will give all the details what we need. And again, smart implants, Zimmer Persona is already there, and they got an app also. With that app, you can know what is the post-operative recovery and all that. Now, wearable technology, you can see that there are two patches, one on the quadriceps, one on the anterior of the tibia. With that, again, virtual follow-up technology through video counseling you can do. I think physiotherapy also will be out of the conventional way. There will be remote or virtual or digital physiotherapists. Now, wearable technology and remote recovery monitoring, again, we have done one study recently based on the skin temperature, artificial intelligence, about 700 patients. That will tell you just by sensory detection of the minute changes of the skin temperature, the wound health, and the likelihood of the infections also. So the latest in the diagnosis and management of TGI, silver-coated implants, mainly megaprocess have come, and these are expensive, but they will make a change in this one. And again, biofilm eradication strategies. These are all going to be very important in the revision surgeries. We all know that biofilm is the bugbear or the number one enemy of the surgeon, because the antibiotics cannot penetrate that. But now there is a phase therapy coming, and future option in the management of TGI in infection with biofilm organisms is the phase therapy, where you inject the phases and they will eat out the biofilm and make the antibiotics much more available. And again, pathogen identification, PCR-based tests have come, small sample, less than 1 ml synovial fluid, within hours it will give you all the antibiotics. And these are the next generation sequencing called NGS, and again, wonderful way to go forward. The surgeon of the future, from simple operator to data-driven decision maker, that is the future. Cognitive skills are more than management skills, again important point. Lot of data, feedback and technology. Treatment process more streamlined. And of course, ethical and emotional touch will be missing where we should put our personal touch. And tell you, my friends, in the future there won't be any Guru Reddys, KJ Reddys and Jairam Pingles. All the MS Ortho guys are same. We can operate as good as any one of us. Thanks to the technology, thanks to the robotics, thanks to the objective evaluation of the outcomes. The experience is taken out of the equation. Am I right? So basically technology, artificial intelligence will give you that much strength and that much power to do well. But of course, at the end of the day, personal touch and your emotional involvement is much more important. Future challenges, data privacy and cyber security, algorithmic bias and regulatory approvals. Surgeons should maintain oversight. Any day surgeons should be able to overtake or overrule the robot. Cost versus access paradox in low middle income nations. Ensuring surgeon autonomy and judgment. So these are the future challenges. No doubt the future is bright, and I'm sure in the next decade, after 10 years when KJ becomes much older and grey haired, the conference will talk about artificial intelligence and machine learning much more. Thank you so much for giving me this opportunity, KJ.
That was a very comprehensive and enlightening talk by Guru Reddy sir of what happens in the future in the year of 2025. We hope that we have all this technology by the next time you come here, sir. I would like to invite our dynamic organizing chairman, Dr. KJ Reddy sir, Professor Jairam Pingle sir onto the dais, and Kanakaraju sir onto the dais. We have a felicitation for Dr. Guru Reddy sir, who has come here spending a time on a Sunday all the way to Mehboob Nagar.
Thank you very much.
We request the TOSA Secretary and past President and President Dr. Ramkumar Reddy sir, please come onto the stage, sir.
Yeah. Thank you very much, Guruva. That was wonderful. I think you had commitment in the afternoon. In spite of that, I think you made it. Like Dr. Jairam Pingale and Dr. M.B. Reddy. And as you rightly said, I think future probably experience may not count to that extent, but people should not go away. That experience, it doesn't matter. I think whatever, I think. So it's important that the experience, people like I think Guru Reddy, Jairam and all the people here, their experience, I think valueless. I think you have to have experience along with the technology, then only it works. But I think the experience probably may not count to great extent in the future.
I'd like to invite Dr. Bansilal Garu onto the stage for the felicitation. Kindly invite Dr. Alva Reddy sir onto the stage.
Photographer.
Thank you so much, sir. We'd like to felicitate the other keynote lecturer, Dr. M.B. Reddy, sir.
అట్లున్నాండి.
Thank you so much, sir. We request Dr. Ramkumar Reddy sir and Mantri sir to continue to the stage as moderators. Thank you. I now invite Dr. Deepti Reddy sir. We are going to start the session on case-based discussion in revision trauma surgery. Starting off from head to toe, we start with the proximal humerus. The topic is on a proximal humerus revision after an implant cutout.
patient, how to convince the patient for revision surgery.
Thank you very much for the opportunity, first of all, and I think it's a great initiative to have complications and how to tackle the complications as a topic for victims evening. Yeah, it's very easy to convince a patient for revision surgery when they can't lift their hand up. If they can't do the function, they would want a revision surgery, and that's where we come in. You have seen the future of orthopedic surgery and you have seen all the complications which can happen in orthopedic surgery. Now we'll go back to basics. Basics of how to do a surgery properly and to avoid complications. So this biggest problem is the cutout. Cutout is the biggest complication you have to worry about. Why do you cut out? Why do implants cut out? It's either implant failure, surgeon failure, or a combination of biology. It's never one factor. It's always a combination of these. Can you hear me now? Yes, sir. Thank you. So this is the varied complications which I get to see in my clinic on a fairly regular basis. I think we should not get to that stage where we see these sort of things. When you look at outcomes, we talk about procedures, we talk about fixations and non-operative treatments. If you look at complications wise, when we fix them, we seem to have the maximum complications there. When we don't fix them, complications are lesser, and patients do manage. But there are a certain set of patients who do require fixation, and that needs to be important. So these are the various complications listed. Today we are going to only focus on the mechanical failure of the proximal humerus fractures. So looking at the complications, the most commonest one is the intraarticular screw penetration, often a problem with technique. Varus collapse, often a problem of technique. Subabdominal impingement, avascular necrosis. Avascular necrosis we don't have much control on, it is biological, and that we have different solutions. Is the implant to be blamed? Some people in our country come out and say nailing is the best thing, plating is the best thing. No. Implant is not very easy. Implant is not the cause. You can see the overall complication rates for both are similar. So there is no difference in the implant. Implant is not to be blamed. It is your technique which is to be blamed. Complex complications, screw penetration. So how do you avoid? Avoiding those always go slow with the drill.
The camera
Feel the bone and drill. Don't just keep going in. Always have your screws short, not like the finger. You should have it at least 8 millimeters off the cut. We'll go with the case examples for each of these things. Continuous screening, AI imaging is very important. Many times you see this picture. That fracture did not even require surgery. Somebody went and did a nailing, and they even had the guts to publish it, to say that it's failed. And in spite of all our efforts, the patient had a good healing. If you look at the staples, the first 3 staples, you had only 3 staples there, at the end you had actually staples. So he ended up with an operation which was not required at all. So indication is important, technique is important, wrong technique. Decision making wise, when do you consider you refix them or replace them? So you should look at linear cartilage, how much is there, how much of the head size, and what are the fragments which are healed, which are not healed, if there is any infection or not, adequate head, femoral head stock is required to fix it. Young patient, try to preserve it, and always check for deltoid and the rotator cuff. These two muscles are the key for shoulder function. So examination wise, look for their active abduction, then you look for passive abduction or elevation, and you look for rotation. This will tell you the rotator cuff is intact or not. If they cannot hold it outwards, that means there is a disconnect between the rotator cuff and the shaft. So deltoid function, state of skin is important. Range of motion is also very, very important. Rotator cuff function dictates what we do for these patients. Example, 42-year-old gentleman fell off a bike, had this injury. Somebody went and fixed it, looks beautiful, looks nice. When you keep following it up, that's what you see. There is something missing on the top there. So there is a GT escape. And that's the incision he has had for his surgery. If you look at the intraoperative picture when we went for revision, because he could not lift his arm up, you see there are two top screws and the humeral head is bare on the top. So there is no rotator cuff at all. That means the whole GT had escaped and gone back. So what did I do for it? I mobilized the rotator cuff, get the greater tuberosity back into the groove where it belongs, and fixed it. So what are the lessons we learned from it? Learning points are avoid proximal screws as much as possible. Only one screw, because two screws actually lengthen the part of the bone where the rotator cuff is attached, so it can pull off. And always suture the cuff. For me, a proximal humerus fracture fixation is not done unless you had a non-observable suture put on all the rotator cuffs onto the cuff. That is an ideal gold standard of fixing the proximal humerus. GT should always be under the plate and below the humeral head. Next example, August 22, this lady, young lady, had fixation done. It looks reasonable, not so good from fixation point of view or the reduction point of view. And you see progresses slowly into this. And next you see 23, that happens. And February 23, completely collapses. This lady, why did it collapse? Studies have shown that if you have cross combination on the medial calcar, and if your reduction is not good, and if lowermost screws are not holding the lower part of the humeral head, they cannot. And other thing is the humeral head should always be below the greater tuberosity. The failure reasons for her, there were no sutures over the cuff, poor locking mechanism. We have got a local implants, we don't lock properly. Locking system does not work, and early mobilization could be a reason. Infection could be a reason. So how do you deal with it? You should always have, this is an example of how it should be done. So that's a proximal humerus fracture. You see the fracture is very well seen on a CT scan. Always get a CT scan for these patients. You will see the extent of the injury. That's the type of reduction you need to get before you actually start plating. Hold it, then pass sutures through the rotator cuff into the plate. So the sutures also correct the deformity. So I think in the proximal humerus, sutures are mightier than the screw and the plate. Sutures, sutures, sutures.